Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McRae.
Osteoarthritis, also known as wear and tear arthritis or degenerative arthritis, is the most common form of arthritis, affecting millions of people worldwide. It occurs when the protective cartilage on the ends of your bones wears down over time. Although arthritis or osteoarthritis can involve any joint in your body, it most commonly affects joints in your hands, your knees, your hips, and your spine.
Although the underlying process cannot be reversed, osteoarthritis symptoms can usually be effectively managed. And here to discuss osteoarthritis and how it can be treated is Mayo Clinic rheumatologist Dr. Shreyasi Amin. Dr. Amin, it's good to see you again.
Thank you. Thank you for having me.
Yep, Dr. Amin, good to have you. So explain the term arthritis to us. I assume arth or arthron, as I think originally a Greek word, has to do with a joint. And the itis suggests that it's inflammation of the joint. It's more than that, though, isn't it?
It is. It is. It's more than just inflammation. There is damage that occurs at multiple aspects of the joint. So you've alluded to already that the cartilage is affected, but it is the entire joint, including the bone and the surrounding tissues, including the capsule and the synovial tissue, which is another lining of the joint itself, and then the surrounding muscles and tissues, including the tendons.
Is this like macular degeneration, for instance? If you live long enough, everyone ends up with arthritis?
Well, genetics does play a role, and damage over time to the joints, depending on how you use and abuse your joints, certainly can affect you. So the longer the older you are, you are more likely to accumulate those forms of damage, for example. But there are people who do very well and have very little in the way of symptoms, although radiographically they may have evidence of arthritis.
So everybody's cartilage wears out over time.
You know, I can't say we've studied everybody, but certainly over time,
Most
that is a likely effect of just wear and tear
Aging.
over the time and loading over the joints, especially the knee, for example.
But isn't it interesting, though, that people who have been sedentary their whole life are just as likely, are they not, to get arthritis?
Well, you know, there are forms of arthritis even in the hands. We're not necessarily walking on our hands. We are using them. But there's been an interesting relation between obesity and hand arthritis. So there's some suggestion that certain molecules that promote inflammation, such as adipokines, might be playing a role. And so that needs to be explored further.
Adipokines?
Adipokines.
Yeah.
So these inflammatory mediators that are thought to be related to more adiposity or fat.
And maybe women have more of those than men, because this is a condition that's more common in women than men, isn't it?
It depends on the age. So in younger years, men may be more likely, possibly related to sports-related injuries, harder to say, but after the menopause, women do have frequent osteoarthritis.
And family history also plays a role, too. If your mom and dad had arthritis, you're more likely to have it.
Genetics does play a role, exactly, especially in the joints of the hands. We find, the smaller joints near the nails, for example.
How does osteoarthritis affect a person just on an everyday basis?
Well, there's two things we think about as pain and then function, and it depends on the joints affected. So, for example, if you have osteoarthritis in your hands, especially at the base of the thumb, that affects grip. And day-to-day activities, when you think about it, we use our hands quite a bit, and we use our thumbs particularly. So that can have an effect on just smaller day-to-day activities, such as squeezing the toothpaste out of for your toothbrush, writing, for example, even smaller items like making a meal, for example, or even using tools. And then when it comes to even recreation, people have trouble holding a golf club or a racket, for example.
So pain, a problem. Stiffness also. Loss of motion.
Yes, pain is one thing, but function is the other. You're right. So stiffness that can affect them in the mornings, or if they've been sitting for a while, we call it gelling. Hard for them to stand up because they're just a little stiff, like a Tin Man, for example.
The painful sting of recognition. Does that get any better, or does it just continue to, as I will get older, as patients who notice that stiffness in the morning or upon getting up and moving around, does that get better?
Well, in the mornings, for example, it does improve with activity or with movement. So most people will feel that they loosen up after a few minutes, sometimes a little longer. As we get older, I think it depends on how we try to help combat the arthritis and what we can do to preserve the joints. So we can preserve both function, but also limit the pain that's associated with it.
Does weather affect arthritis? I mean, you have had patients too, just like I have, who say, I can tell when the weather's going to change. Or weather has an effect on my arthritis and how much discomfort I have.
I think I certainly have that comment from many of my patients, and I believe it has probably more to do with barometric pressure change. So the change in the barometric pressure more than just what it is at one static time.
Yeah, well, it's interesting because they swear it's true. They can tell when it's going to rain or
Absolutely.
if it's going to snow. Diagnosis. How do you make the definitive diagnosis? And then to also tell us the difference between this most common form of arthritis. I know there's 100 different kinds of arthritis, but this one and rheumatoid arthritis.
Well, the diagnosis is based in part by symptoms, your physical examination of the joint that is affected. Sometimes we are able to add radiographs or x-rays to that, and sometimes blood tests help us exclude other things. So blood tests themselves aren't part of the diagnosis. So it's symptoms, the examination of the joints, and the x-rays sometimes will help.
Yeah, there are not any blood abnormalities in patients who have osteoarthritis, but there are in rheumatoid arthritis. And tell us the difference between the two there.
So in terms of the difference between the two, as we talked about before, osteoarthritis is more the wear and tear arthritis that we talk about as we get older, possibly related to other aspects of damage of the joint, whereas rheumatoid arthritis is what we call an autoimmune disease. That's where the body's immune cells, which are there to protect our body from foreign organisms like bacteria, get confused and start to attack the joint, specifically the lining of the joints called the synovium. And then there's production of inflammatory cells that work towards causing not only inflammation that contributes to pain of the joint, but also damage over time to the joint itself. And it's fairly accelerated.
Yeah, the body attacking itself. It's one of those diseases,
Correct.
autoimmune.
Correct.
So it's diagnosed, the osteoarthritis is diagnosed through symptoms,
Correct.
Possibly a scan of some.
X-ray.
X-rays
Most of the
are
time,
mostly
X-ray
just
is all you need.
okay. So
But it's also symptoms and x-rays,
Sure.
correct?
do you then try to figure out ways to manage those symptoms, or then do you look like if pain is something, or what do you do at the next point then, once it's been diagnosed?
Once it's been diagnosed, then we try to help them with the symptoms that are most bothersome. So pain is usually one of the things that bring people to the attention of the doctor, but also function. Try to help preserve the function that they have without causing more accelerated problems over time. And sorry, I should go back to say when we talk about symptoms, it's also trying to discern the types of arthritis. So we ask questions to help us define what might be osteoarthritis compared to other forms of autoimmune arthritis, what we call inflammatory autoimmune arthritis.
I know what else I was going to ask. So it's age-related is a piece in there. Genetics is a piece in there. Who else is at risk for arthritis?
Some of our patients with autoimmune diseases, even though we get them under control, because of inflammation, that contributes to damage of the joint. And once the damage is there, it can increase over time. Patients who have had trauma, so if they've had a fracture through a joint or a trauma to the joint, will increase the risk for damage, accelerated damage.
Is smoking something that makes a difference?
That's a good question. So if you look at studies, smokers in general have a lower risk, and the thought is because they have a lower body weight compared to people, the general population. We've done some studies to show that smokers have more pain in their knee, and that has also been shown in people who have back pain as well.
All right, there's never a good reason to smoke, I guess. All right, we're talking about osteoarthritis, degenerative type arthritis, with a Mayo Clinic expert, Dr. Shreya C. Amin. Time for a short break. When we come back, we'll talk about treatment options for degenerative arthritis, plus prevention of osteoarthritis. And we've got a myth or matter of fact.
Yes, if I develop osteoarthritis, I won't be able to exercise. Is that a myth or a fact? We'll find out.
Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McRae.
We are talking about osteoarthritis, degenerative type arthritis, with Mayo Clinic rheumatologist Dr. Shreya C. Amin. As a matter of fact.
If I develop osteoarthritis, I'm going to have an excellent excuse. I won't be able to exercise. Is that a myth or a fact?
That's a myth.
Good. That's good.
All right, newly diagnosed patient with osteoarthritis, degenerative arthritis. What do you tell them?
Well, it depends on the joints that are affected, but I tell them that they need to help. We need to help them with their pain management if that's one of their main concerns. But also, we talk about lifestyle changes and potential ways of exercising that will help them either gain a better body weight if that's an issue, but also exercises that will strengthen their joints and will help preserve their joints over time, especially at the knee.
So really, when you're talking about exercise, you're not talking about so much about strengthening the joint, but you're talking about strengthening the muscles to take some stress off the joint.
Correct. That's correct.
And activity modification is a big part of it, huh?
It is. It is. I think it depends on what they're doing or not doing. But we also want to make sure that they're doing their exercises with good footwear, good conditioning, warming up beforehand, stretching after, so they don't injure themselves as well.
You like that answer? Like swimming's a great exercise, isn't it, for people with osteoarthritis?
Water-based exercises for people, especially if they have arthritis of their knees or their hips, because that it hurts them to walk or to load bear. So water-based exercises in a warm pool, it doesn't have to be swimming. They can do aerobic exercises or walking in water. That helps get the aerobic exercise they need to help them with weight loss, but without having to put a lot of pressure on their joints. Walking exercises, though, on a treadmill, with good footwear, is important.
What about medications or even supplements? I mean, if I'm just noticing, man, it's tough to turn 50, Dr. Shives. If I'm just noticing that when I get up in the morning, my ankles and feet are sore, or when I get up, from watching a movie or something, what should I be doing?
Well, it depends on your pain symptoms and how long they're occurring. If it's short-lived, I don't recommend long-term medications. If, on the other hand, you have pain with sustained activity or even at rest, then we talk about pain management strategies that are safe. Although acetaminophen may be the weakest medication, it is among the more safe medications as long as it's taken in the right amounts and not overdosing themselves. Especially, we have to think about over-the-counter medications or supplements that have acetaminophen in it, so they don't exceed the maximum required amount.
So you like acetaminophen better than ibuprofen?
Correct, from a safety profile, if people have
Less
to use
side
it.
effects.
Correct. Correct.
And mainly the side effects with the ibuprofen or the NSAIDs, non-steroidal anti-inflammatory drugs, are stomach-related, bleeding-related?
It could be from stomach ulcers or just stomach upset, and stomach ulcers are the biggest concerns, but also it can affect the kidneys. It can also adversely affect blood pressure, or it can aggravate hypertension. And we have to think about their blood counts, and we have to watch that they don't have a drop in hemoglobin that because of occult blood loss that they are even not aware of.
Yeah, but isn't it true, though, the itis, inflammation, is part of this process? Acetaminophen doesn't have any effect on the inflammation, whereas ibuprofen does. So theoretically, wouldn't the ibuprofen-type drugs be more effective?
They are more effective than acetaminophen in some respects because of that effect on inflammation. So I try to use it more judiciously. So if people do have to use something chronically, I prefer to try acetaminophen first and then use the anti-inflammatory pills over short courses if possible.
There are the non-prescription ibuprofen-type drugs, and then there are prescription drugs. Are the prescription drugs more effective than over-the-counter?
Not necessarily. So the over-the-counter doses may be less effective, but if we use them at the therapeutic levels, we can have just as good effect as the prescription forms. We just have to remember that everyone responds to anti-inflammatories just a little differently. So if they fail one, we can try others and see if it's effective for them.
Because of the prescription anti-inflammatory drugs, NSAIDs, there are multiple different ones. How do you choose, and is one better than the other?
I wouldn't say one is better than another, but there are some that are more potent, so they could be more effective than more mild forms. But I think we want to choose one that is safe, tolerable, and effective. And if one is not effective, I move to others.
Are supplements helpful?
It's a very good question. There's been a lot of interest in looking at over-the-counter supplements, but at present time, we don't have a lot of good options. I think one of the more common ones that people have heard about is glucosamine and chondroitin. Current guidelines right now from many societies have not recommended their use at this time.
Is that right?
Correct.
Because I thought it was sort of 50-50. You know, there were half the people it helped and half it didn't help. But now you're not recommending it.
None of the
Glucosamine,
studies.
chondroitin, sulfate.
Correct. Correct.
All right, and then there are those other supplements on the market, and I'm thinking of OsteoBiflex and Arthromax, for example, most of which contain chondroitin and glucosamine. So you're not a big fan?
You know, I do talk to my patients about it. They're always interested in finding something that will help them. I give them the option if they want to try it, that they want to take it for 3 months. If they find it beneficial, then I'm okay with that. But if it doesn't give them any benefit, I don't recommend they continue it, just like any medication or elsewhere.
All right. So, and if those things don't work, then there really are surgical options. I suppose you can get your knee replaced, but is there anything in between those?
Right. So we have other options. So in terms of chronic pain management, if we're just talking about pain, we've talked about Tylenol, NSAIDs, but there are other medications such as duloxetine that is in the antidepressant family, but that has been approved for pain management in osteoarthritis. We also have options of topical therapies. So there are topical NSAIDs, for example, like Voltaren gel. There are capsaicin products, and those have been somewhat helpful for pain management. Then we have intra-articular products, so one of them being steroids that we can inject into a joint. They may have more short-term effects, so I try to use that again in the setting of someone who's had more acute worsening in their pain, and we're trying to get that under control.
All right, so quickly, I want to ask you about several different kinds of injections. Does cortisone increase the breakdown of cartilage?
It can.
Okay, so you use it maybe 3 to 4 times a year. You don't want to get a cortisone injection every week.
Correct. We try to reserve not to use it more frequently than at 3-month intervals if we have to, but if it doesn't give long-term benefit, I don't like to continue using it.
All right, hyaluronic acid, Synvisc and Hyalgan.
So it is approved for the use of osteoarthritis. Whether it's the efficacy, I think, is just a bit weaker. The data is weaker, but I do offer that to my patients if we have nothing else that is helping them and they are not interested in surgical options either.
All right, PRP, platelet-rich plasma injections.
There's a lot of interest in PRP. The quality of the studies right now are a little poor right now, but I think there's more information that needs to be accumulated before we recommend that. So I think it's probably more useful in a study situation.
All right, the evidence is a little shaky. And
Correct.
similarly for stem cell injections?
Correct.
All right, we're talking about osteoarthritis, degenerative type arthritis with an expert, rheumatologist, Dr. Shreya C. Amin. Dr. Amin, thanks so much for being with us.
Thank you for having me.